Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The objectives of the initial patient examination for the patient who presents for prosthetic treatment is to gather the data necessary for making a tentative treatment plan. The routine history and examination of a patient must be emphasized in certain areas which prosthetic considerations must be made. So there are a few things to do with the history that we want to mention, such as the general appearance of the patient, the general well-being of the patient. Someone who is debilitated and etc. could not remove appliances well, would have difficulty in removing appliances. This is a factor in prescribing prosthetic treatment. A systemic debilitating disease, one such as arthritis, this is also something which should be considered. Temporomandibular joint disturbances should be eradicated beforehand, before starting the treatment of the patient. All these things should be taken into consideration. Previous prosthetic experience of the patient should be taken into consideration. They should be questioned and their answers should be related to what you might prescribe as a prosthetic replacement. Sometimes they have had a bad experience with previous appliances, and you should listen to every comment that they make about those previous appliances, and you should examine those appliances. Another thing which is of consequence is the patient's attitude, which you can record during the routine examination to prosthetic treatment. Some patients may not want to spend long hours in the chair. They are too busy. These types of things have to be taken into consideration before prescribing a specific prosthetic treatment. Now, the oral examination has some features in it which I'd like to emphasize, which are characteristically emphasized in the prosthetic examination. Now, the first thing that we'd like to look at would be the teeth and the associated structures. Now, before going on to that, I'd like to mention that many of these things can be recorded on a chart, the Periodontal Chart, which is available in the school. Vitalometer recordings can be recorded on this chart, reactions to percussion, mobility of the teeth, the results of the periodontal examination. Any pockets over 3 millimeters should be recorded on the chart. Any areas of decay can be recorded on the chart. Open contacts and types of restorations and conditions of restorations. All of this information, which we will be subsequently looking at on the patient, can be charted and will be available to you when you make your treatment plan in a summary type of form. Now, looking at the patient, the vitalometer recordings and, as I said, percussion recordings should be made such as they are routinely. The periodontal examination should be made, which is done routinely. And I'd like to show the mobility, the way in which the mobility of the teeth should be recorded. I'm choosing this anterior tooth. You should put 2 hard instruments on the tooth. If you use your fingertips will absorb the movement. Now, I'm going to move this tooth back and forth. You can see the tooth moving. That has a greater than normal mobility. Now, all of the teeth in both arches should be tested in this way, particularly the abutment teeth. The next thing that we might look at specifically from the prosthetic standpoint is the conditions of existing restorations which might enter the treatment plan. Now, looking at the molar area, on this patient, we see that she has an amalgam restoration. The amalgam restoration is cracked, and it has poor margins, so we would make a recording of this. The restoration next to it is also an amalgam restoration on the bicuspid, but it seems to be in fairly good condition, although its margins are not the best. Perhaps during the treatment planning we would want, if we were having to do a restoration on the molar, we would want to do the restoration on the bicuspid at the same time. Now, the type of restoration is very important, for the clasp unit of the removable partial denture should not rest on amalgam, because if it is made of titanium, the titanium will wear away the amalgam and you will get a changing relationship of appliance to tooth. The only surfaces that it should rest on really are a gold surface or an enamel surface. Now we're going to look at the condition of the tooth on the opposite side of the arch, the other abutment tooth, and we see that that tooth is non-restored and is in good condition. It has no restorations and no existing decay. Now, going on, I'm not going to go all over the arch and for this purpose show the existing restorations, but this should be done on every patient and should be recorded because it's going to affect your treatment plan. Another thing that we would like to look at specifically are open contacts on the patient. In this bicuspid area, we want to check to see that the arch is integral. In other words, that all teeth are touching. If we have touching the adjacent teeth in the interproximal, in their interproximal surfaces. Now, if this tooth is a lone standing tooth, that is, there is no contact, if it were that way, we would want to put a restoration in the mouth to close that contact, because the forces of occlusion have a tendency to drift the teeth or cause the teeth to drift mesially. Here we see another patient where the contact is open, and although it is a good tooth, we would want to close this contact either with a restoration or by splinting the teeth together with gold restorations. It is vital that the arch is an integral unit and that there are integral contacts interproximally with the abutment teeth in its adjacent tooth. If they are not there, the appliance will drift mesially with the teeth and causing impingements in the lingual bar area. The next thing that we'd like to look at on the patient is whether or not there is hypereruption of the opposing dentition into the area that is edentulous. The patient has had some gold bridges constructed for the maxillary arch, and during the construction of these bridges, these teeth were most likely, when it closed now, these teeth were most likely reduced in height and have been cut back and restored to a nice occlusal plane. We can see that there is no hypereruption on this patient of the opposing dentition into the edentulous area, because it has already been rectified with gold restorations. Now, in contrast, we can look at models of another patient and see the sequela if a partial denture is not placed into position in sufficient time. We can see with these mounted casts, the lower dentition has erupted to start to touch the maxillary edentulous area. So when the maxillary teeth were lost, these lower teeth, because they were unopposed, continued to drift until they reached the opposing ridge. Now, from the standpoint of reconstruction, this poses an extremely difficult situation. If the teeth are retained, there would have to be bony surgery performed. The teeth would have to be devitalized and cut down, or these teeth may necessarily be extracted with a ridge, an alveoloplasty done to create room for the appliances that would be necessary, namely a lower removable partial and possibly an upper removable partial or denture. We can also see on this cast, if we look just posterior to the teeth, the tuberosity area. And the tuberosity area on these casts is also impinging. Now, if you were to construct a complete denture, you could see that if you covered the tuberosity, such as the practice with a complete denture, that there is absolutely no room. In the same vein, we want to make sure that there is room for the framework of the removable partial denture, because we're going to be placing occlusal rest on the abutment teeth, and so we're going to look very specifically at the abutment teeth to see if there is enough room vertically for the framework. What we're concerned with here is that if a clasp is resting on the distal aspect of the tooth with an occlusal rest in this area here, that there is enough room for the minor connector to come up and be attached to this occlusal rest. There should be enough room with the teeth together also in occlusion so that we have an adequate amount of room or adequate clinical height to the abutment crowns for the primary clasp units or the direct retainers. This is also true in the bicuspid area. We want to look at that tooth to see if there is enough room for the indirect retainer. Or not the indirect retainer, excuse me, but the minor connector. Now, it is important, it is very important also that the occlusal rest be deep enough into the tooth. And so this means that the tooth has to have an adequate clinical height. If the tooth is very short in clinical height, we may choose not to splint because there would not be enough room for a solder joint between the teeth, vertical height. If we plug this area with a solder joint, if we chose to splint two teeth, there would not be sufficient room for the papilla to be healthy. So one consideration when looking at clinical height of the teeth is if the tooth is a very short tooth, we tend to negate splinting that tooth to an adjacent tooth. One thing I haven't mentioned till this point, but that is extremely important, is the oral hygiene of the patient and the attitude toward oral hygiene. Hopefully they would respond to instructions. Areas when they present for prosthetic treatment that you can expect to have plaque would be the teeth opposing the edentulous ridges because they are out of contact. Just the natural cleansing action of mastication and having opposing surfaces come in contact tends to be cleansing. But when the teeth are unopposed, those teeth will have a tendency to accumulate plaque. Also, areas which have a tendency to accumulate plaque are the distals of the abutment teeth, or the areas bordering the edentulous, or the surfaces bordering the edentulous areas. These areas must be given specific attention to remove all plaque. This would conclude then our examination of the teeth and associated structures, and we'd like to focus our attention now on the soft tissues, mainly, first of all, the edentulous ridges. Now, we're going to look at the edentulous ridge of this patient, and first of all, what we're going to want to do is to check the consistency of the ridge to make sure it has bone in it. I'm pressing with the mirror. Some ridges are extremely flabby or loose with fibrous tissue covering, and the residual ridge may have very little bony support. This appears to be, although fairly flat, it does appear to have a firm base for a potential saddle area. The shape of the edentulous ridge is also important. If the ridge is positive and very high, you'd want to look at it for potential undercuts for the base, so that when the partial denture was inserted, it would not be scuffing the tissue. This ridge has a tendency to be, as I said, a little bit flat, so undercuts are not that important. The area as you go toward the retromolar pad will naturally become more and more spongy, and the retromolar pad area, which is glandular in the posterior part, will have soft tissue on it. In addition to the size, form, and consistency of the ridge, we should look at the attachments, soft tissue attachments to the ridge, both the buccal and lingual attachments. Now, we should see how high up onto the crest of the ridge they are, whether there is a large amount of attached gingiva over the crest of the ridge or a small amount. Now, this patient, over the crest of the ridge, there is an area of about 4 to 5 millimeters, a band 4 to 5 millimeters wide, which is attached. Other than that, the attachments are movable and can be displaced. The other soft tissue, part of the soft tissue examination, which we are concerned with, particularly with the mandibular partial denture, is the existence of possible mandibular tori, or bony exostoses in the lingual area or lingual bar area. And we can see the faint blanched areas in the area of the cuspid and bicuspid, or in these areas where there are minor elevations, and those are mandibular tori, but they're not to the extent that they are clinically significant. Now, these tori on another patient are obviously of clinical significance and would necessarily be removed surgically. They may have a tendency for recurrence, and tori also occur in the maxillary arch in the midline. Now, these are something to watch out for. However, when they are only of moderate size, an adequate relief space can be made under the lingual bar of the partial denture to allow for movement of the lingual bar without impingement. Now, the second slide that we're going to show has an area of impingement, again in the tuberosity area and the retromolar pad area. I'm emphasizing this point because it is of it's of prime importance that we have enough room over the retromolar pad between the tuberosity, particularly in this given case where a maxillary appliance could have maybe 2 millimeters of thickness of acrylic, 1 to 2 millimeters, and the mandibular would necessarily have 1 to 2 millimeters of thickness, so that during lateral excursions of the mandible and during function, the appliances would not touch. Now this means that this area would have to be surgically treated to create room for maxillary and mandibular appliances. Now this would conclude our examination of the soft tissues and related to the ridge structures. However, there are other areas and attachments that we should look at and know about in case our line of treatment runs to things such as swing locks and etc. One thing is the frenum attachments. We see that when you put in a removable appliance, a frenum is going to have to move around it or inside of it, so frenum attachments both in the anterior part of the mouth and particularly in the posterior parts of the mouth adjoining the saddle areas are of prime significance. Another thing that we'd like to look at is the tongue. Open. The size of the tongue is extremely important, as well as the mobility of the tongue. Now, if the tongue is large, they will have problems with any type of prosthetic appliance that is inserted. If the tongue is in a retracted position, they may have problems with wearing a complete denture, so that you would tend to try to save the teeth and make a prosthetic appliance or a removable partial denture for the lower arch. Another thing that we look at in the examination of the tongue, as I said, was the mobility of the tongue. And I'm going to insert the mirror, and we'll have the patient make excursions with the tongue to the right and left, and observe the floor of the mouth and the attachment of the lingual frenum to the alveolar crest. And we can see that in this patient it is relatively high. There is, as I'm measuring it with the periodontal probe, there is about 6 millimeters or maybe 5 millimeters from the free gingival margin down to the attachment of the tongue. Now, this may not be enough to allow for a lingual bar, but in this case we might be thinking of a lingual plate for this particular patient. That amount of attachment, or the distance from the free gingival margin, should be recorded also in the patient's notes or on the chart. The saliva is of importance in prosthetic examinations because we want to note the character of the saliva as well as the amount of the saliva. Now, it is said that if a patient has a relatively dry mouth, particularly if they are taking medications, sedative type of medications, the dry mouth does not allow a lubricant layer to be placed between the mucosa and the acrylic of the, or metal of the saddle area. Now this then would make the patient have a tendency to have a sore mouth. So there is a need for a moderate amount of saliva. The character of the saliva, whether it is serous or of a mucus type, is probably important also to a lesser degree. If you have adequate amounts of saliva, you will have retention, for example, of a maxillary denture. So when you're talking in terms of whether the patient is going to have a maxillary denture versus a maxillary partial, both character of the saliva and the amount of saliva are important. Also, unbelievably enough, it's been shown that the more mucus type of saliva is probably better for denture retention, although this is still undergoing some research. The aesthetic considerations are also important to talk over with the patient. Now, we said that the clasp units that lie on the abutment teeth, open and turn to the right, have to be placed on a suitable surface. Now, the suitable surface for clasp retention, namely the labial surface of the tooth, if we're going to use that for our retention, would have to be either enamel, gold, or porcelain. And if it is to be a clasp partial denture, a clasp is going to show on the buccal surface of this bicuspid. So we have to talk over with the patient perhaps the need for, maybe if they do not want to show any gold at all, it would necessarily be a ceramco or a porcelain bonded to metal type of restoration, or something suitable like a 3/4 crown if the buccal surface has an adequate contour. We won't know that until we survey the study cast, but we have to talk over with the patient the showing of gold or of clasps to make sure that they know exactly what they're going to receive. It's of extreme importance. Another thing we should look at in the patient examination is the occlusion. And this is extremely important. The first thing that I like to look at is the relationship between centric relation and centric occlusion to see if there is a discrepancy between the two positions. Now we'll manipulate the jaw and allow her to touch, just touch. And where do you feel that touch? Can you show me?
It could be right up here. We'll say first.
Okay, she feels it touching in the bicuspid area, so obviously it's not a real stable relationship in the centric relation. Now squeeze. Okay, and she has a minor slide. You can do that again. Till you just touch and then squeeze. There's a real small slide between centric relation and centric occlusion on this patient. So there's a real small discrepancy, but we should know exactly that relationship, because if we're to put in an appliance that is going to do no harm whatsoever to the mouth, or trying to put in an appliance that is stress-free, we're going to have to accommodate to the adjusted position. And we may choose, in this case, to do an occlusal adjustment on this patient. Another thing of interest on this patient is if you'll tap, just tap up and down. If we'll look at the lateral incisor, just keep tapping, we'll see a blanching of the tissue in this area, and I can visually see the tooth moving. So we should do an occlusal adjustment on this patient before any type of mouth preparation or any type of abutment preparations are fabricated. We should also record the prematurities on this patient, and this could be done with articulating paper or shim stock or something, some suitable type of indicating material. Now, the articulating paper will do very nicely, and I'm not going to go into that any further at this point, but prematurities in centric relation should be recorded on the patient's chart. Now, another thing we'd like to check on the patient is the vertical dimension of the patient, going through the S sounds, the M sounds, and trying to determine if she has an open, if someone has perhaps in her case increased her vertical dimension of occlusion with her bridge work, or if she has an adequate freeway space. This should be diagnosed immediately before going any further with any type of occlusal reconstruction. In addition, we should observe the lateral excursions on the patient. Close together. Now slide to the right. Sliding to right and left. We should observe for ease or freedom of movement. She does this very hesitantly, and does have there is a degree of difficulty in manipulating her jaw. So we hope to, if this were bad enough, or if she had some history of temporomandibular joint problems, this would necessarily be treated with bite splint and occlusal adjustment first. A minor amount of problem, perhaps we can cure with just the routine occlusal adjustment procedure. This should be done, the excursive procedure should be checked for the guiding teeth in both right and left lateral excursions as well as protrusive excursions. And needless to say, we want no contact in the natural dentition on the balancing side. But all these guiding surfaces in the various excursions should be recorded. Now, one other thing we'd like to record before undergoing or any type of occlusal procedure would be that in the centric occlusion position, whether the patient has contact or not. This is a good indication. Perhaps you could do this now and after the time of the occlusal adjustment procedure, but they should be recorded prior to abutment preparation. This is so we know whether the patient had a contact on the tooth. Open, close. There's no contact there. Open, close, open, close. There's a contact. We should check with a small piece of shim stock all around the arch to check whether there is a light contact, whether there is no contact, or whether there is a definite or heavy contact. And these should be recorded because when you insert the appliance or you insert a crown at a later date, you'll be able to tell if you have inserted a restoration that is too high or not. At that point in time, you can again check with the shim stock, and you'll have a record as to whether you have either opened or closed their vertical dimension. Now, this will conclude the oral exam of the patient and all the information that we have recorded by looking at the teeth, the oral or the ridge areas, the tongue, the saliva, etc. This is all information that we should have on hand to utilize in coming up with the tentative treatment plan for this patient.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.